So if you see a 70-year-old, this is how I think they get to the emergency department. And if you think there's another way to get in, tell me. Direct from our offices, home care nurse in the community, the nursing home transfer, the community emergency, and the ambulance or regional transfer. This is the way people enter the factory. So, when you enter a factory and you're 70 years of age, just by the mere presentation in the emergency department, your chance of being admitted is over 50%. In North America and in Australia and New Zealand, by the mere virtue of a 70-year-old entering the emergency department, 50 to 70% of those people are going to be admitted to hospital. So doesn't it make sense that we do a good screening on those patients when we see them first? Because if they got multiple problems going on, because the people that present to emergency are generally the frail elderly, and we need to know what they're like cognitively. We need to know what their skin status is. We need to know what their mobility status is. We need to know their functional statuses. So it's important that we have a screening tool. Now, how many people in this room who work in the hospitals in St. John's have a screening tool for seniors when they enter the hospital? Can I see a show of hands? And I'm not surprised. There is not. And this will highlight the need for one. ADLs, IADLs. This is activities of daily living and independent activities of daily living. Can you wash yourself? Can you buy your groceries? Again, you see pressure sore risk assessment, fall risk assessment, home and support assessment. It takes 20 to 30 minutes to complete. And if you look at that in your handout, I've put in what I thought was the most comprehensive one I've seen in Australia. Now, this is a catch-all of everything that you would do. But we could easily redesign that for Newfoundland's needs. But it's an example for you to look at. Now, I'm going to walk you through the factory. Patient comes into the front door. 85% of them go this way. They're stable when they walk in. 15% are unstable. They go directly to the doctor, and some of those will end up in ICU or cardiac or surgery. Some will end up going down through medical and surgery. Others will come back into the emergency department after being assessed by some specialist. Then we have this tool. This is the admission screening tool that I talk about that looks at all those wonderful things that seniors should have done. So in the New World, or in the Australian world, this is what I learned that these hospitals are using. These are hospitals with 65,000 visits in the emergency department per year each. Our health sciences has 40,000 visits. Our health sciences, if you take a 70-year-old, has 49% of the 70-year-olds that enter the health sciences are admitted, and that's data directly from our utilization people at the health sciences. So the model is similar. So when a person comes in, they're a potential acute care admission. And I'll highlight that in red, because if we don't sort these out quickly, this is where the dollar sign starts ticking over really rapidly. And this is where care, the delay to treatment, is where the patients are really suffering. And we're increasing the morbidity, mortality rates by not getting here quickly. And we have to get here quickly, and tools like this can get us here very quickly. In Australian hospitals, this tool is administered within 1 hour of the person coming through the door. That's the goal. So the triage nurses who are already in the health sciences can do this. This is not an add-on from the purpose of staff. You can say, well, we don't have time to do it. Well, if you don't have time to do it, these patients here that you haven't adequately assessed will clog up your emergency department. And these are not bad people. These are good people. But the system, the factory, is not working appropriately for them. So this is some background of what I saw in the emergency departments. The 70-year-old and this cohort have the highest probability of admission to a hospital by their mere virtue of coming into the emergency department. I'm saying it again. 49% of these people are admitted at the health sciences. So we have an acute care admission. But look where I'm sending them. I'm sending them to an acute geriatric or medical assessment unit And in a hospital with 65,000 beds, they have 6 to 8 beds there. You said, how in the hell can that be? There got to be a lot more people than that. Well, there are, but there's other places they can go. But the real sick ones, they don't sit on them. And these people that go in these units are looked after quickly. They have priority access to investigations. Every investigation in acute care hospital they have priority access to, and they have priority access to every specialist in the hospital. So what we've done is we've upped the ante on geriatric care. These people don't sit in the corridor in a stretcher. Okay? Now the question is, how do you recognize them? Well, you recognize them because the screening tool will highlight the ones that are in trouble. So if you've got a person that comes in and they have a cognitive impairment and they have high pressure sore risk and they're falling and this person has a fever, well, this person is sick. And this person needs to be very intensively monitored, and they need to be sorted out quickly with a myriad of investigations. And how can you do it if you don't prioritize them? So if you look at these people, the goal is to get them out of the unit in 48 hours, and most of them they do. And 70% of these people go to the general medical ward in the hospital. Instead of what we have in the health science where they go up to the general medical ward or they go all over the place, they are treated as a cohort here, and then this place sorts out where they go in the factory. And these are people now heading for mostly rehab and medical stabilization. This talks a little bit about what you'd see on an acute geriatric unit. 8 beds, higher staff ratios, priority access to investigations, priority consult access. The usual diagnoses here are sepsis and delirium. And you say, well, what are you talking about, Dr. Butler? Well, worldwide statistics show that if you look at that cohort of 70-year-olds who are admitted, 10 to 30% of them have a delirium. Okay? One of the most common forms of sepsis is urosepsis. So these people need to be acutely treated and acutely sorted out. About half the people of that 8 beds will be filled up at any one time with these 2 diagnoses. We are not screening for these diagnoses here, especially this one. And delirium can be very, very hard to pick up if you're not tuned into the subtle signs of it sometimes. Okay? So, the green, by the way, in my slides is how you get out of the factory. So whenever you see a green light, green means go. And the light green means you're almost on go stage. So, in here, the big problem is when you got a person who's delirious in our factory, and I refer to the hospital as a factory, and they're agitated, where do we put them? In Australia, they said, look here, once we stabilize the delirium and we got the person sorted out, the medication problems that are usually the cause of it, the infection is treated, but they need more time now to stabilize. But they're not a medical threat. Let's move them over to an acute behavioral unit. And this is a unit which has an open concept, low stimulation. In other words, there's not people running around all over the place. They got a geriatric psychiatrist and a geriatric nurse. And when I say the geriatrics, we have a beautiful opportunity in this province because we have all these specialties in place. And this is in the acute unit. It's not in the Waterford. It's not in St. Clair's. Or it could be in St. Clair's, but I think it should be in the health sciences. Because by having this unit, now these people can come off the drugs that are toxic to them, and they got time to dry out, literally, before they go home. And then they can get out and get home with some supports in place. Remember, when you have a delirium, it often takes 6 months to clear, and sometimes it never clears. So what happens in our current hospital system is the person got 4 to 6 days to get better. We send them home, and then the family doctor says, gee, you know, Mrs. So-and-so is in hospital. She got home, and she's mixing her pills up, and she's really, really sick, and I just wonder what's going on. And really, the delirium hasn't cleared. And then what happens, they mix up their medications at home, and then the delirium gets worse, and they recidivate right back into the hospital system again. And you know, one thing that's always consistent with every acute care hospitalization, and this is shown worldwide, that every time you go in acute care and you're an elderly person and you come out, you're on more drugs. And guess what is the worst risk factor for delirium? The number of drugs you're on, okay? So, this sounds like a theme, but you can see we got a complex factory, but you see these people are figuring out a way to flow elderly people.